Good evening and thank you for joining us for tonight's dermatology update in partnership with St George Hospital. My name is Bertha Harvey and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. Before we begin, I would like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise a continuing connection to land, water and community and pay respects to elders past, present and emerging. Couple of upcoming events which may be of interest to you. So we have a nurse education on Monday, 24th of March in partnership with St George Hospital, CPR training at St George Leagues Club. And our next session with St George Hospital is on Tuesday, 29th of April, complex sleep disorders. And you can use the QR code or visit our website for more information. And just a couple of the listings of the urgent care clinics that are available in our region. And just some information on the Integrated Care Chronic Disease Network, why they exist and how to get in touch. So you can email Kylie. And just a reminder from Health Pathways that generic logins will not work from the 1st of April. So you will need to register for a personal account for that. Our GP facilitator is Dr. Martina Gleeson, and I would like to introduce our presenter tonight, Dr. Lara Rivero, who is a dermatologist specialising in occupational dermatology, including dermatitis and part testing, and he has practices in Cogra and Darlinghurst. So thank you, Dr. Lara Rivero.
Thank you so much for the invitation tonight. It's for me more than a pleasure to talk a little bit about some conditions in dermatology, and specifically, as the title says, the tree in the forest, or which are the small clues that for the general practice level and even for some colleagues are very useful, particularly diagnosis some challenging conditions. Okay, but we're going to do we're going to present some cases and a little bit of a brief discussion and tips that you can get from these cases in terms of what we have learned when we have been managing them. And with every topic that, if time allows me, I'm going to cover for 3 types of different conditions. After each topic, I'm going to pretty much open the question and answer section for you to ask for any questions or let us know any comments that you might have so far, okay? So pretty much what we're going to learn tonight, or that's what I hope, that you could be able to identify key features on physical examination of certain dermatologic conditions, and keeping that in mind, that might increase the diagnosis accuracy and optimizing the patient's conditions management. These are the conflicts of interest that I have to declare regarding this talk. And we're going to start with the first topic, and you're going to find these titles a little bit bizarre, but it's perhaps for you to then remember those words when you are actually encounter these kind of conditions later on in the practice. So the first condition would be 2 feet and 1 hand, or maybe two. And our first case is a 47-year-old male farmer from country New South Wales that has been dealing with more than 3 years of mildly itchy, scaly red patches on the body and the limbs. He interestingly reported that he has been dealing with thickening and detachment of several nails for several years prior to the onset of these rashes, either prescribed by the local doctor, or he pretty much tried himself medications like antifungals, corticosteroids, or actually the combination of both. And this gentleman actually has had 3 repeat skin scrapings. One of them reported no pathogenic fungi, and the other 2 ones actually no growth, okay? With negative microscopy, by the way. In terms of his background history, reported scalp psoriasis since his teens, and also dyslipidemia, for which he takes rosuvastatin. Interestingly, there is no history of eczema or psoriasis in the family. He lives with his wife and a teenage son in a farm. They have several horses and also look after dogs and cats. And he said that the pets, particularly the dogs and the cats, have been checked by local vets regularly. He was seen by a colleague about a year ago and was diagnosed with inverse psoriasis. He was treated with oral acitretin for about 4 months with no benefit. And then he was switched to methotrexate. The itch abated, but the rashes were slowly worsening. And this fellow dermatologist was actually considering putting him on a biologic agent. And interestingly, his treating GP actually decided to request a second opinion, considering how stubborn and how bizarre the rash actually was looking. And this is actually what we can see today on examination. Well, sorry, not today. I mean, when we saw the patient, that pretty much you can see a distal onycholysis with subungual hyperkeratosis and yellow debris on quite a few, almost most of the fingernails, but not all of them. Interestingly, there was no pitting or salmon patch on the nails affected. And you can see actually, oh, sorry. And you can see the well-defined erythematous scaly patches affecting both the dorsum and the palmar surfaces. And this is actually perhaps one of the first things that we need to start to consider. That is the appearance of the scale. There is not that sort of gross, thick scale that we tend to normally see in psoriasis. It's actually more fine. And then we have the involvement of both feet, as we talked initially, and also with well-defined patches and plaques that actually go upwards the ankles with a little bit of patches also on the legs. Perhaps this photo is not that helpful because the photos of the toenails were a little bit blurry, sorry for that. But also he has similar changes on the toenails. And he's right-handed, and interestingly, when we dig a little bit further with questions, actually, he recalled that the problem on the skin actually started on the feet, and then it started on his dominant hand, and a few months later, that's when it started to appear on the other hand. And this is actually when alarms ring, so to speak, because also you can see these well-defined patches with some annular areas, actually, or even some annular patches, and some of them isolated of confluent, that barely involves the scrotum. And there are some areas actually of tiny pustules as well, okay? Because this patient actually comes from the countryside, we triage or referrals first, and pretty much we advise the patient to stop all the topicals because he was still using the self-prescribed combination of corticosteroids and antifungals, and only use emollients with menthol for each relief until review that happened about 3 weeks after we triage the referral. We performed some repeat baseline bloods, and when we saw him on the appointment, we actually did nail clippings, adhesive tape samples for PCR, and skin scrapings performed. And the PCR for dermatophytes was actually positive from both the nail and the skin samples. The skin samples, and the nail clippings and the skin scrapings actually both reported a positive microscopy and a positive culture for trichophyton rubrum. The patient was advised, therefore, to stop the methotrexate and to start combined oral terbinafine with topical terbinafine on the affected areas, and to use urea 30% on the affected nails. And 6 weeks after the appointment, because he lives in the country area, we gave him a call after starting the treatment with considerable improvement of the rashes. His GP has actually been monitoring the treatment, and she was really grateful about us managing the case. And then the follow-up phone call 3 months later, the rashes completely gone and the nails improving substantially, while he was still taking the oral terbinafine and using the topical terbinafine in the affected areas. We did not decide to do a biopsy at the time of the consultation. And then we have our second case, that is a 31-year-old female housewife from the Central Coast, close to the Hunter Valley area, with 1 year of intensively itchy, scaly red plaques on the body and the limbs, particularly on the genital area. She tried self-prescribed topical antifungals, and then her local doctor also prescribed some, and likewise with the other patient, topical corticosteroids or combinations. Sometimes she uses over-the-counter topicals with tea tree oil or eucalyptus oil. Her local doctor performed a scraping that actually reported just growth of Candida albicans. She was prescribed oral fluconazole, but due to personal concerns in terms of side effects, the patient decided not to go ahead with the treatment. She had a background history of eczema in his childhood and has been taking just some over-the-counter supplements, but not regular prescribed medications. Also, no family history of eczema or psoriasis, and she lives with her husband and 2 children in a house with no pets. Her husband sometimes complains of a growing itch, but she's unsure about any rashes on him. And this is the genital area. And actually you can see also a very well-defined plaque that extends from the genital area towards the groins and the upper abdomen. You can see a little bit of maceration on the folds and also a little bit of peripheral pustules that you might see in some of the areas. With asymmetric, that's also a very useful clue, an asymmetric involvement of the buttocks. And also you can see this sort of irregular distribution on the legs that on a closer look, you can actually see that this is a plaque with quite ill-defined borders, with some excoriated papules on the center or a mix within the plaque, with some peripheral micropustules in some of the affected areas as well. Interestingly, she was wearing nail polish, but she denied any substantial nail involvement. We performed repeated scrapings from the leg and the groin, and we isolated Trichophyton interdigitale from both the leg and the groin rash. But on the groin also, we isolated Candida albicans heavy growth. We had a lot of discussion about the concerns that she had regarding the side effects from the oral antifungals. And then because she was taking some herbal supplements and the potential interactions with azoles like fluconazole, we asked her to stop them. She was started on oral itraconazole in combination with miconazole and hydrocortisone cream for 2 weeks, and then continue with only the antifungal until completing 8 weeks of treatment. The reason of us doing so is because in a phone call 4 weeks later after starting the treatment, she reported substantial resolution, but still some active rashes. And despite being a standard guide to use the treatment for 4 weeks, in some cases, we might need to actually prescribe it for a little bit longer, at least until we have achieved clinical resolution for at least 1 week. Then a follow-up phone call a couple of months later, the itch and the rash was mostly gone, just some areas with post-inflammatory hyperpigmentation that is occasionally itchy, and with the background of eczema and how intensively pruritic these lesions were, we were thinking about the possibility of changes suggestive of lichen simplex, which in that case would not require to continue the antifungals. And this is more related to the effect of the rubbing and the scratching when the lesions were active while she was not treated yet. So when we mention the 2 hands and two feet and 1 hand, it's because when you have a patient that has this sort of psoriasis-like rashes, but the distribution is not quite even or symmetric, the scale is not the typical silvery white or thick scale on those areas, and it's just 1 hand affected. In most cases, that's tinea until proven otherwise, okay? Interestingly, when you have nail changes, like on the first patient, for example, we need to consider differentials, including those ones that you can see there, like psoriasis, lichen planus, yellow nail syndrome, traumatic, toenail misalignment. Particularly keep this one in mind for changes on the big toe, that you can have the thickening of the nail plate with yellowy discoloration, and you do repeat nail clippings with negative fungals or maybe just no pathogenic fungi, and you treat the patient with topical or even oral antifungals for several months with no benefit, check just quickly the anatomy of the toes, if there is an accentuation of the deviation of the toes, or if the patient actually is wearing ill-fitting shoes, because toe misalignment actually can cause changes like this. Alopecia areata on the nails, particularly when you see pitting, and age-related nail dystrophy, particularly in elderly patients. And if we talk about psoriasiform rashes on the skin, differentials that we might have for annular rashes, particularly like discoid eczema, that tends to be intensively pruritic in most patients. Annular psoriasis, which is not common, but has been reported. Annular lichen planus, also a quite uncommon entity. Granuloma annulare, particularly when you have that sort of very firm infiltrated edges of the ring of the patch or the plaque. And the erythema annular centrifugum, where pretty much you see the red ring with a trailing scale That's very suggestive of that. And ironically, this sometimes can be also a manifestation of tinea on other parts of the body. So if for any reason you see a patient with erythema annular centrifugum, that you see pretty much those sort of expanding rings on the trunk or the limbs with trailing scale, check for tinea, particularly feet and groin areas, okay? Pityriasis rosea, that is another differential for annular rashes, and subacute cutaneous lupus, particularly on sun exposed areas. So as I said before, remember, if there are any scaly rashes in a distribution of 2 feet and 1 hand, this is highly suggestive of tinea until proven otherwise. So what happened here, particularly with the first patient, that the local doctor did the right thing in terms of doing the samples and getting negative results? So what should I consider? There are some fungal infections that actually can have low fungal burden, particularly for epidermophyton, for example, and that could potentially cause a false negative. Improper specimen collection or contamination. If you want to reduce the likelihood of the samples being contaminated by non-pathogenic fungi, you might rub the area a little bit of alcohol and drain that up quickly before actually you do the scraping, for example. The third item is very important. If the patient has been using topical or oral antifungals, there is no standard recommendation, but perhaps the consensus is that the patient needs to stop the treatment at least 2 weeks prior taking the samples, because otherwise the possibility of a false negative result is actually far higher. Delays in the processing that sometimes can cause contamination of the samples. Obviously, as any test that we perform, there could be potentially laboratory errors, or there are some limitations of the diagnostic method employed. That's why we're trying to rely on PCR, for example, for samples of the skin and the nails. That is available, but just in certain areas. It's not widespread or around Australia. And interestingly, St. George was actually one of the centers that was part of the trial of standardization of the PCR testing for skin samples to rule out tinea, and actually the results were really good. Some fungal species can be actually quite fastidious or quite difficult to actually grow in culture. If the inflammatory reaction is actually quite strong, particularly if you need to do a biopsy, for example, that might obscure the visualization, sorry, of the hyphae within the skin. And especially with PCR, because of the threshold of detection, there might be some changes that might require a reassessment and retest of the quality controls employed. So what is our advice? The topical corticosteroids generally don't affect the isolation of dermatophytes. The cream definitely should be wiped off before the scraping. Each side needs to be collected separately because it's not common, but sometimes you can have 2 different dermatophytes isolated. Collect as much specimen as possible to maximize the yield, and that's why some pathology places are actually providing the black boxes, so it's actually easier for both you and the technician to see how much of the scale is actually has been collected. For the skin scrapings, use the blade at an angle, usually or ideally on the active edge of the lesion. If you try to actually take from the center, probably you are not going to isolate the hyphae or the fungi. And also the recommendation to clean with alcohol, as long as it's not severely excoriated, because alcohol on an open area stings. But this also reduces the likelihood of contamination with bacterial species like staph, strep, or pseudomonas, particularly on the legs and the feet. For nail samples, use the nail clipper to clip the infected portion of the nail plate. And that's why sometimes we recommend it to do twice. To reduce the likelihood of the contamination, you might just remove the distal edge first and discard that. And then you take another clipping. That's the one that actually you are going to send for pathology. And if possible, if there is some subungual debris, that's also very helpful, that you can actually scrape with the blunt side of the blade. Or with the blunt side of the scalpel as well. And in children, we can actually collect hair specimen with pretty much damp a sterile cotton swab and then rub it against the area. That in most cases of tinea capitis, the hair is already really loose, so you can actually traction it just with a very gentle rubbing on that area. In adults, actually, you might need to brush or even pluck some hairs with the forceps. And I'm not sure if you guys have been seeing that, but interestingly, from certain areas of Sydney in particular, we have seen quite a few cases of tinea capitis in adults, but actually more for Trichophytomenta gravitis. There are some theories around why this has been happening. I'm not going to go deep into that. But one of the things that you do need to tell the patient is to check the utensils or the tools that the barber shops are using when they're actually having the haircuts. Because it seems that is one relatively common finding that some patients have actually said that going to X place, what place or Z place, that's actually when the problems started, okay? So I'm just going to hold up there for a moment, and I just want to double check with Martina in the Q&A section if there is any questions or any comments so far regarding the first condition, 2 feet, 1 hand.
You are speaking so clearly that everybody understands and there are no questions.
Okay. Oh, well, that's really good. Or actually, I should be concerned. Okay. Let's go move on then. I think, yes, we are good with time. Very good. Black pepper in boiling water. Okay. And in this case, actually, I'm going to present pretty much 2 cases in parallel because the findings are strikingly similar. These are actually 2 female patients in their mid-20s with the history of recurrent boils on the genital area, have been seen by their local doctor several times and have been prescribed topical or oral antibiotics, such as the ones that you actually can see there, and sometimes even antiseptic agents or washes, including benzoyl peroxide, or in some cases, the combination of these topical corticosteroids, antifungal, and antibiotics that are available on the prescription. And in both cases, actually, the treatment helps, but then after a few weeks or within a few months, the condition recurs. This is actually when things become a little bit different because our first patient, actually a very healthy patient with no positive background history on no medications, non-smoker, no family history. Whereas the other patient, actually, you can see that there are a bit of issues with weight management. She has the background of PCOS. She had severe acne as a teenager that required oral isotretinoin, and her father also had severe acne and also history of recurrent boils in the buttocks. Very busy at work, sedentary lifestyle, and smoking 3 to 5 cigarettes a day. When we examine those patients, actually, you can see, interestingly, the paucity of lesions, but this is actually, I was trying to zoom them more, but sorry, it was a little bit blurry. Actually, on the left, you can see that this is an area that one of the lesions that that underwent incision and drainage. But this is actually what I would like you to focus on. This that looks like a small cyst, but this thing here, this thing here, this thing here, this thing here, that looks like blackheads, pepper. And on the right side, sorry, you can see this one here and this one here that also looks like pepper. And in this one in particular, if you have a closer look, I'm going to zoom in a moment with another image taken from a website. These are actually double-headed comedones. And then the first question that you immediately would like to ask is, do I normally have comedones on the armpits, on the groins? And the answer is basically no. And do I normally see double-headed comedones, for example, when I'm seeing acne? And the answer is also no. And why I would like to present that? Because the double-headed comedone, I think perhaps in this close-up, you have a better example like the one that I'm pointing out here or pointing out here, is that it's a very highly sensitive finding for hidradenitis suppurativa. I know that particularly when examining the groin, if you want to have a closer look, there are some patients that might feel a bit uncomfortable for obvious reasons. What I might suggest, if you have a magnifying lamp, or actually if you ask the patient, so you can ask the patient their mobile phones, take a photo, and then just pretty much zoom in, and might say, oh, yes, looks like a blackhead, that looks like a comedone. That on that areas is precisely very highly suggestive of hidradenitis suppurativa. And that can make a big difference because research studies that have been done in Queensland and in Victoria report that on average, a patient might spend between 3 to 7 years before seeing a dermatologist until the diagnosis of the hidradenitis suppurativa have been made. Obviously, there are many things that we need to keep into consideration, including number one, sometimes how easy or not so easy is to have an appointment with a dermatologist. Number two, we need to understand also the financial situation, that sometimes in terms of cost, the patients might refrain to go ahead with the appointment as recommended. But it's also important that even when the main differential of this condition is precisely chronic or recurrent folliculitis, this is actually a very useful clue when you identify comedones, because the earlier that we intervene and treat this condition, the better prognosis in terms of slowing down the progression or the appearance of complications. So what you can do at your level in terms of helping us as well, and most importantly, helping the patient. The general measures including loose fitting clothing and antibacterial washes, that minimize the effect of minimizing the rubbing is very important, because that might cause flares with tight fitting clothing, for example. Try to encourage a smoking cessation and a healthier lifestyle, including proper diet and exercise. Identify any comorbidities and potential associations with hidradenitis suppurativa as a chronic inflammatory condition, including spondyloarthropathy or any inflammatory arthritis, inflammatory bowel disease such as Crohn's or ulcerative colitis, insulin resistance or metabolic syndrome, PCOS, severe acne, and pyoderma gangrenosum. For some of these conditions, actually, sometimes just asking some very specific questions on system review. For example, do you suffer from any morning stiffness or pain on your lower back or on your hands and wrists? Do you suffer from constipation or bouts of diarrhea out of the blue? Have you been losing weight, or actually have you found difficulty losing weight? If you had as a teenager or are still dealing with problems with bad acne, for example. Check if other areas are involved, and this is also something that I would like you guys to remember. That is what we call the AAA. It hasn't been fully proven, and it seems that it might not be like a rule of thumb. But interestingly, this condition tends to affect the areas where we have apocrine glands. And if you remember the letter A, and we actually remember the AAA battery, so you can remember to check for symptoms on the axilla, on the areola, and the anogenital area. That tends to be the areas that are more frequently affected by this condition. And this belongs to what we call the tetrad of follicular occlusion, and that's also something that sometimes you can also ask or confirm with a very quick questions, set of very quick questions, sorry. If they have very difficult or cystic acne, if they have a pilonidal cyst, do you feel a lump on your tailbone, for example, that? Or if they have very bad abscesses or furuncles on the scalp. That might point towards this condition called dissecting cellulitis of the scalp, okay? What are the differential diagnoses when we have those kind of conditions, particularly when they are really inflamed? The possibility of cutaneous Crohn's, particularly around the genital area. In sexually active women with a painful ulcer on the genital area, you need to rule out certain STIs, If it's more like papulopustular, even just superficial bacterial infections, including impetigo, folliculitis, and furunculosis, and related or not to chronic carriage of staph aureus. And in that case, sometimes doing swabs, not only from the lesions, but also from other areas, like, for example, nostrils, armpits, and groins, can be helpful to see if this patient could be potentially a chronic carrier of staph aureus. As I mentioned before, considering other associations, sorry for this that has been repeated. And perhaps one of the most challenging aspects in hidradenitis suppurativa is actually managing pain. And this is actually when you guys might need to try to organize a coordinated care with a treating dermatologist and also with perhaps a pain management specialist, because when the lesions are active and inflamed, or when there is a chronic ulcer on the affected areas, the pain can be very disabling for the patients. And a pain management specialist needs to be involved in that case, because sometimes they might require advanced therapies to help with pain relief while we're trying to control the disease. In terms of options, perhaps, as we have seen before, oral antibiotics like tetracyclines is usually one of the treatments that we tend to recommend the most. But if you want to actually think ahead a little bit and perhaps give a big flag to the dermatologist in terms of the potential urgency of the appointment or the treatment that we might prescribe, using the treatment for 3 months at least, between 3 to 6 months. There are some specialists that might use it even for up to 1 year. However, what we might say that if they require more than 6 months of treatment and they're still experiencing intermittent flares, we prefer to consider advanced therapies like biologics. And precisely part of the criteria to prescribe biologics for hidradenitis suppurativa is that the patient has to fail at least 2 antibiotics for 3 months each. There is one exception, and depends on how confident you feel doing that approach, is that in hidradenitis suppurativa, we can also use the combination of clindamycin and rifampicin. And if we actually do that, we can shorten the treatment for only 3 months, so that if the patient fails, we have already ticked the box for the patient to go on biologics for hidradenitis suppurativa. There are other specific criteria in terms of the early stage. It has to be at least 2, and the count of lesions, at least 3 abscesses or nodules on the affected area, to pretty much tick all the boxes of the list for the patient to undergo a biologic for hidradenitis suppurativa. And I might stop now with my case, and it says the 3 and 4. I just want to double check with Martina if there are any comments or any questions in the Q&A section.
There's no questions, but I've got one.
Yeah.
You said 2 antibiotics, so presume doxycycline for the first. Would another tetracycline be the second antibiotic, or is there something else we should offer the patient while they're waiting to see the dermatologist for a biologics assessment?
Yes, that's actually a very good question. And to be fair, I actually had to ring Medicare because it was a little bit of a gray zone when they specify that. But it actually should be a different category. If you don't want to do the clindamycin rifampicin combination, you can do just the clindamycin by itself. That's not a problem. You can also use erythromycin. That might be helpful for some of the patients. And to be fair, also some patients might have prescribed, for example, Bactrim. I have to be honest, I have some colleagues that use Bactrim with no problems and good results. But because in the hospital setting that I have seen a few skin reactions due to Bactrim, I have my reservations of using Bactrim for that long. But it's
You
not
only need
wrong.
to see Stevens-Johnson syndrome once for
Yes, indeed.
Bactrim.
Exactly. So, you know, I have colleagues that they do it and they haven't had any problems so far, which is good. But to be honest, I have my own reservations about using trimethoprim sulfa for that long.
I have got a question now. Usually if we start the questions and they start rolling in, so
That's okay.
thank you. How do you diagnose cutaneous Crohn's?
Yes.
Would they have to have a history of diagnosed Crohn's, or do you do it on a skin biopsy?
That's a very good question. Thanks for that. To be fair, cutaneous Crohn's without the gastrointestinal involvement, or to be the cutaneous manifestation, the first manifestation of Crohn's, is exceedingly rare. The patient either has not been diagnosed or has been playing with symptoms without the patient actually looking for help. That's why perhaps the diagnosis of cutaneous Crohn usually goes higher on the list when a patient actually comes with a history of inflammatory disease and these very recalcitrant nodules and ulcers around the mouth or on the genital area. But to confirm the diagnosis, you need a biopsy. And it also is important to specify in the details, not only how the lesion looks, but also if that is your differential, so the pathologist can keep that in mind. Because depending on the type of granuloma, that might perhaps confirm the diagnosis of Crohn's, or actually if you need to think about different granulomatous conditions that might mimic this problem as well.
If you've got a patient with Crohn's and you're considering that, they might already be on a biologic, mightn't they? So
with a skin involvement is highly likely because that means that the disease is behaving a bit more aggressively. And in that case, it will be coordinating care with the treating gastroenterologist, rheumatologist, or immunologist in terms of choosing which options should be better for this patient. Because interestingly, right now under PBS, we have the TNF-alpha like adalimumab or the anti-IL-17 like secukinumab. There was a little bit of controversy in the past regarding the effect of IL-17 blockers and potential flares of inflammatory bowel disease. Recent studies, it seems that the risk is not as high as we thought before, which is actually quite reassuring. But still, we tend to see among dermatologists and rheumatologists that we prefer, as a matter of safety, to go with the TNF-alpha first if we think that there might be association of hidradenitis suppurativa with inflammatory bowel disease, for example.
Getting back to the HS lady, is there any role for metformin in her treatment? Because
Actually, yes. Interestingly, when it's treated on patients without evidence of insulin resistance or metabolic syndrome or PCOS, the treatment as monotherapy is not that fantastic, so to speak, but it still helps. And that's why even now, this is, by the way, this comment is actually an off-label indication, okay? That actually there are some case reports of topical metformin for HS grade 1, which is actually quite interesting. But again, this is like case reports. We still need to have or to run more studies to see if it's really helpful. But it's actually, usually we tend to use it as an add-on treatment, particularly on patients with insulin resistance, metabolic syndrome, or PCOS.
Thank you. I haven't seen any more typed questions, but there is a comment of appreciation on your presentation so far.
Oh, thank you. Oh, that's very nice. Thank you. All right, I think we are actually, yes, we're actually doing very good with timing. So that means we can actually go to the last two cases. I hope that you guys are not getting that bored with me. And this is pretty much called Mirror, Mirror on the Wall, Am I a Raccoon? So I actually put that title because we have these two female patients also on their 20s with several months of these itchy red scaly patches on the eyelids, you know, raccoons. I don't know if you can see actually my dark circles, but anyway. The first case, actually, she has a history of atopy, both personal and family history. And she uses a lot of skincare products sourced from locally or from overseas. You cannot imagine how many brands of Japanese and Korean cosmetic products I have actually learned so far. But it's something that's pretty much happening at every level, you know? And also something that you're also very familiar with, the steroid phobia. The patient is pretty much really adamant of using even mild cortisons like hydrocortisone because of the topical steroid withdrawal, okay? Whereas the other patient, actually, she wears contact lenses. She does not have any history of atopy. She uses the treatment as prescribed by her local doctor. That helps, but it doesn't clear completely. And she has been using the same brand of skincare products for years. I need to do a stop here. And this is actually a quite useful clue, especially because in my case, working with allergies and contact dermatitis, the companies tend to reformulate the products from time to time, either because there are some actives that are no longer able to be sourced, or if there are actually problems with certain preservatives that are causing allergies. For example, remember MINCI, that's something that is still around, but there actually has been on downtrend among the skincare and cosmetic products. And, or for example, if they want to pretty much change the texture of the formula, so that means that actually they can change the components as well. So when the patient says, oh, you know, I've been using the same shampoo, the same soap, the same night cream for many, many years, still that is not something that you should pretty much take for granted, because the product might have changed during that time, the composition of the product, sorry. And then we can see here, again, what do I say precisely? The example of the raccoon, because you see these very well defined red scaly patches that go around the eyelids. But what I would like you to see particularly is what we call the cream sign. Could you actually see the bit of normal skin between this area and the hairline? And actually you can see here too, between here and the hairline, completely normal skin. That is actually what we call the cream sign. We're going to talk about that again in a moment. So we studied both patients, to check for atopy or other features and to potentially rule out other differentials. In one of our patients, precisely, everything was pretty much normal. We performed allergy testing, and actually she was reacting to two of the products. So one was an eye serum and another a night eye cream. That she was obtaining from overseas. And we pretty much had a blank patch testing, but she was reacting to the products. And these products sometimes can contain 30, 40, 60 chemicals on the list. So it was actually very difficult to narrow down the specific allergen, but we pretty much asked her, you know what, please stop everything, simplify your skincare routine, don't stop experimenting with your face. And doing that, she reported actually a substantial improvement, but she was still having some flares here and there. So how diligent was actually the patient in terms of not overusing cosmetic products? We cannot tell. Whereas in the other patient with the features of atopy, we can see a slightly elevated IgE and RAS for malassezia low. Why do I use the RAS for malassezia? Because in patients with suspicions of long-standing seborrheic dermatitis, particularly when you have the involvement of scalp, face, ears, and neck, hypersensitivity to malassezia can cause superimposed dermatitis that is sometimes quite difficult to fully control and might require a different approach in terms of how to reduce the overload or the hypersensitivity of the fungus on the skin, because you cannot get rid of malassezia. That's actually part of our normal flora. But we also perform patch testing, and even if you were wearing contacts, the surprise was that I was actually reacting to lanolin. And she said, hang on, I was actually the same brand of this product. Sorry, I cannot tell the brand. For so many years. And she also reacted to the night eye cream as well that contained lanolin. And pretty much we asked her to stop using products with lanolin, and her eye rashes completely clear, which is good. That's one of the few things what I like about doing contact dermatitis, because it's one of the areas in dermatology when if you find the answer, you can sort out the patient problem. So when we see patients with dry eyelids and eyelid dermatitis, and this is something that I'm sure that you have seen a lot at GP setting, what are the differentials that you need to consider? Then let's go first from the common ones. Contact dermatitis is usually on the top of the list. The irritant forms can be related, for example, if they're using regular soaps or quite harsh or alkaline soaps. Sometimes what they use as makeup remover from the eyelids, for example, or if they are actually using quite rough cloths or wipes to pretty much get rid of that, the wipes as makeup remover. Remember what we talked a while ago about this preservative called methyl isothiazolinone? There are still some brands around that contain it. So it's something that you need to check with the patient as well. Atopic dermatitis, particularly in the adult setting, can affect the eyelids as well. Seborrheic dermatitis, a clue for seborrheic dermatitis, if you see that they tend to form this sort of mildly annular patches on the eyelids, that is actually what we call petaloid eczema, that is highly suggestive of seborrheic dermatitis, okay? This is perhaps one of the most difficult differentials because of the presentation, that is rosacea or periorificial dermatitis. Because particularly in periorificial dermatitis, you don't always can see that sort of florid population that you see around the eyelids, around the nostrils, or on the malolabial folds. Sometimes you just see scaly rashes, and you actually treat the patient with topical corticosteroids, they respond, and then they started to develop the tachyphylaxis, which means that the patient says, oh, I just need to use the cream for longer, or I feel that I need a stronger cortisone because it wasn't as good as before. This is something that might point you towards perhaps the diagnosis of periorificial dermatitis. And in that case, it's better to actually switch to a calcineurin inhibitor like pimecrolimus, for example. Perhaps the problem with pimecrolimus is because it's made on a cream-based formula. So it has some alcohols as solvents, or to make the formula a little bit more liquidy. And it might sting, actually, when you put it on. So that's why we dermatologists tend to prefer to use compounded tacrolimus. On the eyelids, I prefer to use 0.03% as an ointment. and to use once or twice daily, and is generally better tolerated, can be used for longer, and also puts the patient at ease in terms of steroid phobia. I was told by a company that perhaps we might have a brand of tacrolimus by the second half of the year. This has not been fully confirmed. I'm just putting the idea out there just for you guys to be aware that we might have finally a brand of tacrolimus later on here in Australia. Finally. Other differentials, contact urticaria, and this is a little bit more tricky because the reaction tends to be more immediate. And infections, like, for example, bacterial, viral, fungal, and parasitic, such as Demodex or Pityrius pubis. Uncommon causes of dry eyelids and eyelids, particularly in older patients, think of xerophthalmia in the context of Sjogren's syndrome, for example, sarcoidosis. If you see the dermatitis with persistent swelling like angioedema, please consider the diagnosis of dermatomyositis, because sometimes it might be one of the initial manifestations, okay? Cutaneous lupus, side effects of medications, and extremely rare that can be a paraneoplastic manifestation, especially if it's something suggestive of dermatomyositis. Okay, and now we go to the cream sign, precisely because that area of skin spare between the eyelids and the hairline is because the patient, and you actually notice when you're actually putting your cream on your eyes, you don't like to go on the hairline because, you know, it then gets stuck with the hair and makes things a little bit messy. So you try precisely not to reach that area. And if you develop the contact dermatitis, that's pretty much an area of spare skin. Let me just go back, that you can see a very well-defined area of spare skin between the dermatitis of the eyelids and the hairline. Okay. So what can cause contact dermatitis on the eyelids? You can see all the list and all the things that we dermatologists need to think of. Because this might require a special type of testing, perhaps what I would like you to keep on mind on this list is actually two things. Number one, ensure that the patient simplifies their skincare routine. You might see that in some cases, they might be using 5, 6, 7, 10, 20 products on the face, okay? In other cases, the possibility of aeroallergens, if it's also combined, for example, with symptoms like rhinosinusitis or flares of asthma, you might need to consider, for example, aeroallergens like fragrances, grass or pollen, dust mites, mold. And if it's a patient that is working in the building industry or, for example, dental technicians or dentists, remember, please, epoxy resins, they needs to be confirmed through patch testing, okay? And what could be a potential screening for patch testing? Because patch testing is cumbersome and is expensive, okay? So if you want to discuss with the patient a way to try to narrow down if this is related to an allergy to a product that the patient is applying, or actually if the patient would like to have a reassurance about the products that can or cannot use on the face, in the allergy contact dermatitis clinic, we recommend usually the repeat open application test. So how we do it? Pretty much either on the arm or on, the arm or the forearm. We pretty much use like a 50-cent coin size area, 3 by 3, we might say. We pretty much you apply the product. If it's a rinse off product like a shampoo or a conditioner, apply to leave it for a couple of minutes and then rinse it off. If it's like a cream or a serum, just leave it on. And they need to apply twice daily for 2 to 4 weeks. And I say for 2 to 4 weeks because there are some products that might react earlier, whereas there are others that actually might take longer time. Example of those ones, ophthalmics or eye drops, over-the-counter eye drops, lubricating eye drops, antihistamines eye drops, medicated eye drops. You might need to perhaps do it for a little bit longer. If doing that, there is no reactions, you might say that the product could be safe to use on the face. And I say could because the threshold of tolerance on the face is a bit lower compared to the arm because the skin on the arm is actually thicker. But if something is happening there, definitely don't put it on your face, and that might require proper patch testing for confirmation. And the good thing about this technique is because it's cheap, the patient does it themselves. We might have some answers actually like a sort of a screening tool. And this was actually an article very interesting when they compare repeat open application test with a proper patch testing, using the patch testing results as the standard. The sensitivity was 83% and the specificity 100%, which means that if nothing is happening there, it's quite likely That's not the cause of the problem. With a positive predictive value of 100%, so you mean positive result, likely to confirm, and a negative predictive value of 70%. Okay. Good. So perfect timing, because pretty much we have finished our last set of 2 cases. I just wanted to check then again with Martina if there are any other questions, comments from these last 2 cases, or if you have any further comments from the other cases in the past.
Thank you. There is one more question, but you've partially answered it, I think. The question was, can GPs do patch testing and how?
Okay.
And you've described this patch testing, but I know there's others as well. So
yeah, the precisely repeat open application test is something that can be done perfectly at GP level, because pretty much the instructions are there and it's very easy to perform. You should not see any sort of reactions at all. Sometimes you might see a little bit just of peeling skin, for example, with rinse of products like soaps, shampoos, or conditioners, but the area shouldn't feel itchy or shouldn't be erythematous, let alone develop like a sort of eczematous reaction on that area. And that might be like a sort of your screening tool. Because sometimes certain chemicals can have specific patterns of patch testing. And it's difficult to interpret unless you actually have been doing this quite regularly. There are some kits that you can buy, like for example, the True Test. But I'm not that happy, because when they actually run a study in Melbourne comparing True Test with the ABS, that's what we call the Australian Baseline Series by the Patch Camps team in Melbourne, the sensitivity is to capture positive or relevant allergens is actually higher when you use the ABS than when you use True Test. And also some weak results sometimes can be difficult to interpret or put into context. So that's why perhaps unless you have a proper allergy training, which I know that some of you guys have done it, I prefer for patch testing to be done by immunologist or dermatologist. Because you might spend the same amount of time with one patient for patch testing than seeing other 3 or 4 patients. That's why not many specialists like to do patch testing. So, okay.
do you do
a
patch
bit of
testing
self-advertising.
do you do patch testing or do you refer on?
No, I do them. I actually
Right.
do it both in Kogarah and in Darlinghurst. So yeah.
That's really good news. Thank you. There is a question in the chat. Just a reminder to please try and use the Q&A for the questions. But the question is, can pustules be present for contact dermatitis of the face area, or does that suggest an alternative diagnosis?
Oh, that's actually a very good question.
It is.
And
Yep.
depends on the product, because you can have what we call irritant, because sometimes when we think of contact dermatitis, we immediately think of allergy. And that is something that even for me took me a little bit of time to actually step down that idea. Because contact dermatitis pretty much means the dermatitis of whatever you're applying on the skin. But it's irrespective of the nature of the reaction. You can have actually occlusive contact dermatitis, which means if you're using a very thick or rich oily formula on the face that might occlude the oil glands, that might give you pustules. There is actually a form of dermatitis to, for example, sunscreens that actually shows with pustules, but it's actually not a true allergy. It's just the occlusion of the oil glands by the sunscreen chemicals. So, however, there is one exception, although right now that's something that we barely see. With the application of topical iodine, you could develop something called halogenoderma. That is pretty much a pustular reaction related to iodine or products that contain fluoride or bromide. And I'm going to shoot myself in the foot because I'm going to open the can of worms. There are some patients with periorificial dermatitis with pustular reaction that there are some case reports that switching the patient to a low fluoride toothpaste can improve the problem. But if you put a patient on a low or a fluoride-free toothpaste, you are going to have the dentist after you, in terms of long-term care. So this is a bit of a tricky situation, but trying to pretty much be more specific in terms of your answer, because sorry, sometimes I like to talk too much. When you have a pustular reaction, you need to think of, number one, how thick or how rich is the product that the patient is applying on. Number two, if there is some exposure involved. Number two, if there might be something smeared from the contiguous or the surrounding areas that might be explaining the problem. And number two, if there is no superimposed infection.
Lots of things to think about. Thank you. It just makes me think about, we see angular cheilitis on some people. And I read that avoiding toothpaste that's got SLS in it can sometimes help with that. Is that
Indeed.
something?
There is actually we have been pretty much a bit fixated with benzalkonium chloride and granular parakeratosis, but actually we have seen changes on patients that have been using product with SLS, for example, as a perpetuating or complicating factor. And SLS is actually quite no irritant that has been used in certain toothpaste or a lot of cleansing products as well. So that's something that we also need to consider as well in terms of optimizing the patient care and reducing any sort of irritant elements on the area.
The question about the waiting time for patients to be seen when referred to the public hospital clinic at St. George.
Okay. Depends, because as you might check on the website.
You have to triage.
Yes.
It's on the health pathway.
Yes. We are trying to pretty much prioritize certain conditions, like, for example, suspicious pigmented lesions for melanoma, drug reactions to certain chemotherapy agents, including potential contact dermatitis-like reactions. Those are the ones that usually tend to go higher on the list. Or, for example, conditions in pregnancy. They usually tend to go higher on the list in terms of priority. For example, irritant or allergic contact dermatitis, excuse me, perhaps something that makes a big difference if we think that is occupational, because that actually goes higher on the list. And the reason is because we need to try to ascertain this quicker, because that might have long-term implications for both the patient and the employer. So that's why we tend to prioritize those kind of referrals.
But you are taking referrals from GPs now?
From the public hospital, yes. However, to do patch testing, my lovely St. George Hospital still has not allocated a budget for that. So I have to do it as a private patient, unfortunately.
Thank you for making that clear. There's another question. I have a 15-year-old boy who presents with recurrent posterior hairline folliculitis. Both bacterial and fungal swabs are negative. Should he be treated with oral antifungals? Oral antibiotics trials have failed.
Perhaps the question that I might need to ask to the patient from the audience that presented this case is if when the lesions heal, they actually leave keloidal papules on that area, because that might be acne keloidal of the neck, okay? And that is one of the few conditions when actually you might need to consider topical or even intralesional corticosteroids. If the lesions are not leaving residual keloids, another clue that might be helpful if you see what we call tufted hair, which means that you can see like 3 or 5 hairs growing from the same follicular opening.
Mm-hmm.
And that can be a marker of a neutrophilic follicularis, like follicularis decalvans. And that requires a completely different approach. Can antibiotics help? Yes. Antifungals depends on the cause. Sometimes seborrheic dermatitis can cause pustules. It's not common, but sometimes it can do it. But precisely if you do a swab with a pustule and the microbiologist actually does not report any yeast, I don't think antifungals are going to be useful. Although we might need more information regarding this patient to actually give a better advice, to be honest.
Excellent. Somebody's just said, thank you, you've been very concise. Are there any other questions? Or the person who posted that question about the folliculitis, is there more detail that we can add? Oh, local steroids didn't help.
Okay. So in that
Sounds
case,
like they might need
I
you
think you
to
might need a
look at
proper derm assessment, I might say.
Yes, we do try to save our patients from
No.
having to wait for a specialist, but there comes a time, doesn't there?
Yeah.
Are there any other questions? Something's coming up. Lots of thank you for a great talk. Oh, here we go. What are your thoughts on nasal Bactroban to prevent folliculitis?
Absolutely. Especially even in some, because interestingly, we have it as a standard protocol for decolonization of golden staph. However, there are some reports from Canada and from the Netherlands, if I recall correctly, that even in some cases of recurrent staph by, for example, staph londinensis or pathogenic forms of staph epidermidis, that it still can be useful. So, for example, if you have these patients with recurrent folliculitis that you do the swabs, it reports gram-positive cocci, but no pathogens isolated after 48 hours. That's usually the report when I say, oh man, seriously. Still, it might be useful to try the Bactroban inside the nostrils. Twice a day for 5 days. You might need to do either for 3 or 6 months.
What, isn't it?
Yep.
Thank you. We've come to the end of the time. It's 8:30, so and I don't have any more questions. So I just want to say thank you very much, because that was a very interesting talk.
No, thank you so much for
Lots
your
of food for
attention. I
thought.
just pretty much trying to present things that actually I know that sometimes can come across at the GP setting. I think that in this last slide precisely, remember how to contact us in St. George. Although if there is something new or that needs to be updated, Martina, please feel free to correct me just in case. Remember also on the website that we also have updated information about the conditions that we manage or that we unfortunately don't manage at St. George because of the limitations that we might have. But please feel free to reach us if you have any questions or any concerns in this regard.
Thank you very much. Bertha, will I get you to close?
Thank you, Martina. Thank you so much, Dr. Lara Rivero. That was a very interesting and practical talk, and obviously by all the comments from the GPs, very well received. Thank you to everybody for attending as well tonight. So you should see the evaluation link in the chat, but also it should pop up on the screens once I end the webinar. Thank you again, everybody, and enjoy the rest of your night. We'll see you next month. Thank you. Bye.
Thank you.
Bye-bye.